Hello, this is the third lecture in this course on antibiotics. The topic is their mechanisms and classification. The major learning objectives are first to understand the difference between bacteriostatic and bactericidal antibiotics. Second, to know the major mechanisms by which they work. And last, to know the common antibiotic classes. I'll also be spending a few minutes talking about the initial discovery of antibiotics. Before I go further, I'd like to start by simply defining the term antibiotic. It is actually an imprecisely applied term, generally used to describe any compound, natural or synthetic, that inhibits the growth of or actively kills microorganisms. Where do antibiotics come from and how long have they been around? Those of you with an interest in the history of medicine might recognize this man, or at least his name. Alexander Fleming was a professor of bacteriology at St. Mary's Hospital in London. One day back in 1928, he was sorting through some routine petri dishes on which he had been growing bacteria for an experiment, and he came across this one. These small circles occupying the lower half of the plate were colonies of the bacteria Staphylococcus aureus. This large circle at the top was a contaminant that was not intended to be there, which was later identified as the mold Penicillium notatum. The fact that there was contamination could have resulted in Fleming tossing the plate out and not thinking twice about it. However, he noticed that something peculiar had happened. The Staph aureus colonies nearest to the mold had started to die. He hypothesized that the mold had secreted a compound that inhibited the growth of bacteria, a compound later named penicillin. Unfortunately, this seemingly revolutionary discovery did not immediately lead to a revolution in medicine because the technology at the time made the compound difficult to isolate and impossible to produce in quantity. So this finding remained an uncelebrated scientific curiosity until these two guys from Oxford, Florey and Chain, learned about it 10 years later. They were the first to actually administer penicillin to human patients in 1941, and when it worked, focused their lab's efforts on developing a means to mass produce it, which was achieved within just a few years. Thus was born the modern era of medicine, and an accomplishment that earned all three the Nobel Prize in 1945. It is likely the summative efforts of these men saved more lives than all other Nobel winners put together. And it is somewhat unfortunate that only Fleming seems to be remembered in contemporary times. But nevertheless, the story of penicillin is a fantastic example of how a history-altering discovery can be made from an experiment that could initially have been deemed a failure. One of the most fundamental properties of any one antibiotic is whether it is bacteriostatic or bactericidal. A bacteriostatic antibiotic inhibits bacteria from reproducing, but doesn't otherwise kill them, while a bactericidal antibiotic actively kills bacteria. Unfortunately, for people that like to memorize lists and discrete properties of drugs, in reality there is not a sharp distinction between the two, as categorization depends upon drug concentration and bacterial species. For example, the antibiotic class of macrolides are generally considered to be bacteriostatic, but one member, azithromycin, has bactericidal properties against strep pyogenes and strep pneumoniae. The drug linezolid is bacteriostatic against staph and enterococcus, but bactericidal against strep. The class of quinolones, interestingly, displays a single concentration at which they are the most bactericidal, and paradoxically become bacteriostatic at higher concentrations, possibly from dose-dependent inhibition of RNA synthesis. It might seem obvious that killing bacteria would be preferred to simply inhibiting their growth, and indeed there are some situations in which bactericidal agents are traditionally preferred over bacteriostatic. These include endocarditis, meningitis, osteomyelitis, and neutropenia. However, there is no evidence that bactericidal antibiotics are on average better than bacteriostatic ones in most clinical situations. I'm now going to discuss the mechanisms of antibiotics. There are three major ones. Some antibiotics interfere with cell wall synthesis or maintenance. They can interfere with nucleic acid synthesis, or they can interfere with protein synthesis. These three mechanisms will help to start delineating antibiotic classes. This gray oval will represent a bacterial cell with its nice thick cell wall. For the purposes of this diagram, it won't be necessary to discriminate between gram-positive and gram-negative cell structure. And let's start with those antibiotics that inhibit cell wall synthesis or function. First and foremost, these include beta-lactam antibiotics. This is a very diverse class of antibiotics which has subclasses and sub-subclasses. It can be broken down broadly into penicillins, cephalosporins, carbapenems, and monobactams. I will talk more about these in a few minutes. Included in this general category is also vancomycin and daptomycin, which despite the similarities in their names and their coverage are structurally quite different. And there are the polypeptides. The polypeptides include bacitracin, which is a major component of common over-the-counter antibacterial ointments, as well as colistin, a relatively toxic drug used for only the most highly resistant Pseudomonas and Acinetobacter infections. The next category is those drugs which inhibit nucleic acid synthesis or function. This can be a consequence of inhibition of the enzymes DNA gyrase or topoisomerase 4, as is seen with the quinolones. It can be the consequence of an inhibition of folate synthesis, as seen with a specific antibiotic combination trimethoprim sulfamethoxazole. And it can be the consequence of the generation of free radicals, which interact with the DNA strands, leading to DNA damage, as occurs with metronidazole and nitrofurantoin. Then there are the drugs that inhibit protein synthesis, that is, drugs that work on the bacterial ribosomes. Those that inhibit the 50S ribosomal subunit include the macrolides, clindamycin, linezolid, streptogramins, and the much maligned but highly effective chloramphenicol. Those that inhibit the 30S subunit include the aminoglycosides, tetracyclines, and the relatively new antibiotic tigecycline. And for those of you who are wondering if there's any reason to remember which inhibit 50S versus 30S, there really isn't, except for tests. In reality, actually in clinical practice, there's absolutely no reason to make that distinction. I'm going to take a closer look at the beta-lactams. This is the first, most diverse, and most commonly used class of antibiotics. All beta-lactams share this common structural feature known as the beta-lactam ring. This allows them to irreversibly inhibit enzymes responsible for the final step in the synthesis of the peptidoglycan layer of bacterial cell walls. These antibiotics are generally bactericidal. As I mentioned earlier, there are 4 subclasses of beta-lactams. Here is the general structure of the penicillins which all members share. As I started the lecture with, the first penicillins were not synthesized but rather discovered. These are the so-called natural penicillins, which consist of benzothine penicillin and penicillin G. There are the aminopenicillins, sometimes referred to as the penicillinase-resistant penicillins, which include amoxicillin and ampicillin. Anti-staph penicillins include nafcillin and dicloxacillin. And anti-pseudomonal penicillins include piperacillin and ticaracillin. Here is the common structure of all cephalosporins. Cephalosporins are typically described in terms of generations. First generation cephalosporins include cefazolin and cephalexin. Second generation cephalosporins include cefotetan. Third generation includes ceftriaxone, cefpodoxime, and ceftazidime. Fourth generation includes cefepime. And the fifth generation includes the brand new antibiotic ceftaroline. The carbapenems don't have an additional breakdown and essentially include just 3 members: Meropenem, Ertopenem, and Imipenem. Finally, the monobactams only include one clinically relevant drug, as Trionam. At this point, I'm going to get into some more details about some specific groups of antibiotics that will hopefully help you to appreciate the basic differences between classes and between individual drugs within the same class. Over the rest of this lecture, I will be displaying some basic antibiotic susceptibility tables. I wanted to explain the relatively simple notation ahead of time. In this sample, we have 3 drugs listed horizontally and 5 categories of bacteria listed vertically. You'll notice that Pseudomonas is listed separately from gram-negatives, and MRSA is listed separately from gram-positives. This separation when discussing antibiotic susceptibility is typical, as many fewer antibiotics are effective against these specific bacteria. So what do these pluses and minuses mean? 2 pluses mean that, in general, coverage of this category of bacteria by this drug is excellent. 1 plus means that, in general, coverage of this category of bacteria by this drug is fair. A plus minus means that coverage is inconsistent and not reliable. And a minus sign means that there is little or no coverage. So how does this work? How do we use this kind of information to make clinical decisions? Imagine that you know a patient's infection is being caused by gram-positive cocci in pairs, that is, by something that is definitely not MRSA. For example, a patient with suspected pneumococcal pneumonia complicated by bacteremia. Drug X would be the best choice as it gives you excellent coverage for what you need and as little unnecessary coverage as possible, which is important to help prevent this development and propagation of antibiotic resistance. Now, what if you had a patient with a significant risk of being infected with MRSA? For example, an IV drug abuser presenting with fever and a new heart murmur. Drug Y would be a better choice. Finally, if there was a patient presenting with ventilator-associated pneumonia in whom both MRSA and Pseudomonas were significant possibilities, you would conclude that no one drug could provide sufficient coverage, so the best option might be to give both drugs Y and Z until the causative microorganism has been identified. And remember, antibiotic susceptibility is significantly affected by geography and patient population. Referencing hospital-specific antibiograms is highly recommended when choosing antibiotics. So let me talk a little bit about penicillins. In order to understand the categorization and clinical use of penicillins, one must be also familiar with enzymes called beta-lactamases. Beta-lactamases are a collection of diverse enzymes which can cleave the beta-lactam ring of an antibiotic, inactivating it. They are most commonly produced by gram-negative bacteria. And to combat this, some penicillins are combined with beta-lactamase inhibitors, which themselves are beta-lactams that can irreversibly inactivate beta-lactamases by triggering secondary chemical reactions within the enzyme's activation sites. These beta-lactam, beta-lactamase inhibitor combinations are standardized and branded. For example, the brand name drug Augmentin is composed of a standard combination of amoxicillin and clavulanic acid, the structure of the latter shown here. Unicin is the combination of ampicillin and sulbactam. The ubiquitous Zosyn is the combination of piperacillin and tazobactam. You can see that all of the beta-lactamase inhibitors are themselves beta-lactams. The addition of the beta-lactamase inhibitor significantly increases the spectrum of activity of these drugs so that they can be used against bacteria which are commonly resistant to the penicillin antibiotic alone. What does the spectrum of activity for the penicillins look like? Here we have some major categories of bacteria. You'll notice that the strep coverage does not include strep viridans, as none of the penicillins have good strep viridans coverage. Natural penicillins, on rare occasions known as first-generation penicillins, have fair MSSA coverage, that is, methicillin-sensitive Staph aureus, excellent coverage of non-viridin strep, fair Enterococcus coverage, and fair anaerobic coverage. Next up are the aminopenicillins, on rare occasion known as second-generation penicillins. Their primary coverage is Enterococcus and anaerobes, but they also cover non-viridin strep and if combined with a beta-lactamase inhibitor, provides some coverage for MSSA and gram-negative organisms. The anti-staph penicillins, despite being, quote, third generation, which sounds impressive, essentially only cover one organism very well, MSSA, though they also cover a little non-viridin strep. Finally, the anti-pseudomonal penicillins, such as the combination piperacillin-tazobactam, also known as piptazo, or Zosyn, as I just mentioned, don't just cover Pseudomonas, but also all gram-negatives and anaerobes, with fair coverage of most gram-positives. So in other words, piptazo is a very broad-spectrum antibiotic. The next class of drugs are the cephalosporins. As I mentioned a minute ago, the cephalosporins have 5 generations which closely correlate to their spectrum of activity. You'll notice that the gram-positive row here explicitly excludes enterococci, which is because no cephalosporins have any enterococcal coverage at all. First-generation cephalosporins have excellent gram-positive coverage and fair gram-negative coverage. Second generation has decent coverage of gram-positive, gram-negatives, and anaerobes. The third generation covers gram-positives and negatives very well, with a little less anaerobic coverage. Ceftazidime specifically has very good coverage of Pseudomonas. You'll notice that both second and third generation cephalosporins appear to have equally good gram-negative coverage, but probably most people believe that third generation is slightly better. Fourth generation, such as Cephapem, is similar to third generation, but with more solid and consistent anti-pseudomonal activity. Finally, one of the newest significant antibiotics on the market, at least in the United States, the fifth generation ceftaroline, has excellent MRSA coverage. In general, especially for those viewers without much clinical experience to which to reference during this lecture, these charts may be a challenge to remember. Luckily, when it comes to the cephalosporins, this can be greatly simplified as the following. Each generation provides one organism type that should be considered its primary coverage, and one or two organisms that are the secondary coverage. So first generation is directed towards gram-positives, excluding MRSA. They have no good secondary coverage. Second generation is directed towards anaerobes, with also activity towards gram-positives and gram-negatives. Third generation is primarily directed at gram-negatives, with gram-positives as secondary coverage. Fourth generation is for Pseudomonas, but also gram-positives and gram-negatives. And fifth generation is for MRSA, as well as other gram-positives and gram-negatives. In other words, if you wanted to use a cephalosporin against an infection that you suspected was caused by a gram-negative organism, such as a UTI, you should preferentially choose a third-generation agent. Whereas if you suspected MSSA and streptococci, such as in a patient with cellulitis who has no MRSA risk factors, a first-generation agent would be most appropriate. And remember, no cephalosporins cover Enterococcus. Next up are the Carbapenems, Imipenem, Meropenem, and Ertopenem. These are fairly straightforward drugs because they have a very broad spectrum of activity. It is easier to remember what they don't cover rather than what they do. So they don't cover MRSA VRE, that is vancomycin-resistant Enterococcus, Acinetobacter, Stenotrophomonas, and atypicals. Imipenem and Meropenem are active against Pseudomonas, while Ertopenem is not. Imipenem is inactivated by human dehydropeptidase 1, so it is always co-administered with cilastatin, an inhibitor of this enzyme. And one major downside to the otherwise fantastic carbapenems is that they are only available in IV form. Next up are the quinolones. There are literally dozens of different quinolones out there, with some available in one country and others available in another. It would take an hour to review them all, so I'm only going to focus on the 3 most commonly used in the United States, which, for the most part, are among the more commonly used worldwide. These are ciprofloxacin, levofloxacin, and moxifloxacin. You can see their structural similarities and also notice that they all have a fluorine attached to the central benzene ring. This fluorine is present in the vast majority of quinolones, hence the commonly used substituted term for these drugs of fluoroquinolones. Although quinolones are sometimes also placed into generations as listed here, there really is not a standard as to how this assignment is determined, and it may vary slightly from source to source. Some common features of quinolones are that they are generally considered to be bactericidal under most circumstances. They have excellent absorption and bioavailability, though should probably not be taken simultaneously with cations such as iron, calcium, and most antacids due to chelation within the GI tract. Most, including the 3 just listed, are available in both IV and PO forms, that is oral form, which increases the ease with which a patient can be transitioned from IV to oral antibiotics upon discharge from the hospital. Finally, they are widely distributed, with the notable exception of poor CNS penetration, and moxifloxacin in particular has less renal clearance and should therefore not be used to treat urinary tract infections. Let me quickly review the spectrum of activity of the 3 big quinolones. Among the gram-positives, ciprofloxacin only covers MSSA, but has excellent gram-negative and pseudomonal coverage with fair atypical coverage. Levofloxacin covers gram-positives, gram-negatives, atypicals, and a bit less so pseudomonas. And moxifloxacin covers gram-positives, gram-negatives, atypicals, is okay for anaerobes, but does not cover pseudomonas at all. Furthermore, at least in the western United States, E. coli resistance to quinolones has increased dramatically, and in this part of the world, none should be used as empiric treatments for UTIs. The final class of antibiotics I'll talk about in more depth in this lecture are the aminoglycosides, which, if you recall, inhibit bacterial protein synthesis. They are bactericidal and are most commonly used for serious infections caused by aerobic gram-negative rods, including Pseudomonas, though they are not usually used as monotherapy for Pseudomonas unless there are no other options with which they can be combined. Aminoglycosides are not used as monotherapy for gram-positive infections, but are sometimes used in combination with a Beta-Lactam or vancomycin for synergy, especially for endocarditis. Development of resistance is uncommon, and their use is limited by relatively serious toxicities, particularly nephrotoxicity, ototoxicity, and neuromuscular blockade, the latter of which makes them contraindicated in myasthenia gravis. All aminoglycosides are available in IV form, and tobramycin is also available in an inhaled form, most commonly used in patients with cystic fibrosis. These drugs otherwise have poor lung penetration. The dosing and monitoring of aminoglycosides is a little bit complex and will be discussed in a future lecture. That concludes this lecture on the mechanisms and classification of antibiotics. I know that there were a lot of lists and charts, but sometimes in the field of infectious disease, there is no way around it. Lectures 4 through 7 will each review one category of bacteria and their best antibiotic coverage. The newer and more exotic antibiotics, such as daptomycin, colistin, and sinucid, will be discussed there.